Hello, how are you? This is Dr. Zaid. Today I'll be presenting my first presentation about the pediatric immunology chapter. It is about the evaluation of suspected patient with immune deficiency. So our objectives for this presentation are to learn how to approach a pediatric patient suspected to have immune deficiency and to be able to put an investigation plan for that patient. At the end of the presentation, this is for the pediatric residents, I'll be presenting some of the questions which are related to my presentation. The question resources are from Musawi and from other books. Okay, so let's start. Now, the number of children suspected of having primary or secondary immune deficiency are far exceeds the number of actual cases or the numbers you can find in books because as most patients with recurrent infections don't have an identifiable immune deficiency disorder. If the immunodeficiency, if diagnosed early, appropriate treatment can be instituted before irreversible damage happens. So, what will prevent the physician from early diagnose these patients? First of all, low index of suspicion. It will not come to the physician mind sometimes. It will be the least among the differential diagnoses. The second thing is primary immune deficiency diseases are not screened for at any time during life. Like for example, in the neonatal screening test, for example, the phenylketonuria disease, the incidence for it is 1 in 16,000, but there are some diseases which are immune deficiency and under immune deficiency category, and the incidence is 1 in 10,000, which is relatively more common, but still not screened for. Third thing is most affected do not have abnormal physical features. Not necessarily if the patient have immune deficiency to have normal physical features or congenital anomalies. And the fourth thing, extensive use of antibiotics may mask the classic presentation of many primary immune deficiency diseases. So how to approach? We will go through history, then family, especially family history, physical examination, and investigations. So for the history, you will start with asking about the age of onset of symptoms, because it will be different, and accordingly we will focus more about specific differential diagnosis. If there is a problem with T cell, then we should expect early onset, usually 2 to 6 months of age. If the problem with B cell, it is predominantly B cell defect, onset after maternal antibodies diminish. So we are expecting the symptoms to appear after 5 to 7 months of age, later childhood to adulthood. If the problem with the granulocyte, early onset, complement defect, onset, it can onset at any age. So, we will continue the history part. So after asking about the symptoms, we will dig deep in the symptoms. We will see how severe it is. Then we will move to the birth history. Birth history, ask everything about the birth history. And after that, if there is any congenital malformation, especially the delayed umbilical cord detachment, unusual faces or ears, and bony dysplasia. Then we will move to the medical history. Usually the patient with a primary immune deficiency, they will have a significant medical history. So we will ask about the number of admissions and the admission diagnosis. For example, if the patient had a pneumonia, and if possible, what organism, it was, especially if there is any pneumocystis jirovecii pneumonia. And we will ask about if the patient had a severe progressive infectious mononucleosis Like there are patients will have simple EBV, but some of them will have this severe progressive infectious mononucleosis, and it is significant to know this information. If the patient had Staphylococcus pneumonia, if the patient have a pneumococcal as a complication of the pneumonia, if the patient went through severe varicella or osteomyelitis or recurrent osteomyelitis or progressive dermatomyositis with a chronic enterovirus encephalitis or any recurrent nasal meningitis. All these information are important. We should ask about recurrent infections, number of fevers, name of pathogens if possible for pneumonia and abscess, if there is any surgeries done like incision and drainage in recurrent staphylococcus abscesses. Okay, early diagnosis of the condition called leukocyte adhesion defect is which is happening, and usually some of the symptoms will be delayed umbilical cord detachment in these conditions. So early diagnosis of this condition is crucial because it can be treated before any symptoms. It can be treated with stem cell transplantation, and it can be life-saving for these conditions. After that, in the history part, we will move to the review of systems. We will ask generally about failure to thrive, short stature, fever. We will ask about if there is any fine hair, coarse facial features, persistent thrush, draining ears, sinus infection, recurrent sinus infection, ocular telangiectasia, and oral ulcers. Then we will move to the respiratory if there is any cough, heart disease, diarrhea, atopic eczema, pruritic dermatitis, nail dystrophy, oculocutaneous albinism, and splenomegaly, blood stools, hemolytic anemia. After that, in the family history, we will see if there is anybody have similar symptoms or recurrent admissions or early death in the family, and some of the diseases, immune deficiency diseases, they are X-linked, autosomal recessive, or autosomal dominant. Most immunologic defects can be excluded at minimal cost with the proper choice of a screening test. We cannot do all the screening tests. The screening tests should be broadly informative, reliable, and cost-effective. Did you know that if CBC and manual differential were performed on the cord blood of all infants, severe combined immune deficiency could be detected at birth by identification of lymphopenia? This condition is a pediatric emergency that can be successfully treated by stem cell marrow transplantation in more than 94% of cases if diagnosed before serious untreatable infections develop. So moving to the labs, we will start with the screening. There is CBC and differential count, ESR. There is screening for B cell defect, screening for T cell defects, screening for phagocytic cell defects, and screening for complement deficiency. We will go through one by one. For the CBC and manual differential, what we are looking for in it: leukocytosis, neutropenia, thrombocytopenia, small platelets, Howell-Jolly bodies. ESR, in the screening test for B cell defects, we will see the isohemagglutinins, antibody titers, IgA measurement. If abnormal, we will do the IgG and IgM measurement. For the T cell defects, we will do the absolute lymphocyte count, Candida albicans intradermal skin test. And for the phagocytic cell defects, we will do absolute neutrophil count, respiratory burst assay. And for the complement deficiency, we can do the CH50. The after screening rules. Patient found to have abnormalities on any screening test should be characterized as fully as possible before any type of immunologic treatment is begun, unless there is a life-threatening illness. Some abnormalities may prove to be laboratory artifacts, and conversely, an apparently straightforward diagnosis may prove to be a much more complex disorder. For patients with recurrent or unusual bacterial infections, evaluation of T cell and phagocytic cell functions is indicated even if results of initial screening tests, including the CBC and manual differential immunoglobulin levels and CH50, are normal. So the process of doing the labs in immune deficiency, starting with screening, then moving to advanced tests, then moving to special tests. For the B cell deficiency, the screening tests. So I told you before, we will do IgA. If abnormal, we will do IgG and IgM, plus the IgE. If this comes as positive, we can confirm it by doing something called B cell enumeration, looking for CD19 or CD20. After that, we will do special tests to confirm the diagnosis, which is advanced B cell phenotyping. There is another screening, it is called isohemagglutinin titers. There is an information for this. Isohemagglutinins may be absent normally in the first 2 years of life and are always absent if the patient is blood type AB. Okay, if it comes positive, we will do biopsies, like biopsy the lymph node. For the third screening test is antibody response to vaccine antigens like tetanus, diphtheria, pneumococcus, Haemophilus. Because most infants and children are immunized with DTaB or Haemophilus influenza type B or a pneumococcal vaccine, it is often informative to test for specific antibodies to diphtheria, tetanus, Haemophilus influenza, polyribose phosphate, and pneumococcal antigens. If it came positive or negative, we can do the antibody responses to boosters or to new vaccines to confirm the result. If it came also, we can also confirm it by doing antibody responses to special antigens like bacteriophage and mutation analysis. There is an information for this antibody testing for the vaccine and the booster. If the titers are low, measurement of antibodies to diphtheria or tetanus toxoid before and 2 weeks after a pediatric DTaB or DT booster is helpful in assessing the capacity to form IgG antibodies to protein antigens. Patients with significant or permanent B cell defect do not produce either IgM or IgG antibodies normally. Okay, this is an information. If results of antibody titers test prove them to be normal and the immunoglobulins remain low, studies should be performed to evaluate the possible loss of immunoglobulins through the urinary or gastrointestinal tracts. Because in some diseases they will lose the immunoglobulins, like in the nephrotic syndrome, protein losing enteropathies, and intestinal lymphangiectasia. For the T cell deficiency, we can do these tests as a screening. We can do lymphocyte count, chest X-ray examination for thymic size, and delayed skin tests like Candida and tetanus toxoid. For the lymphocyte count, the advanced test, it is T cell subset enumeration, CD3, CD4, and CD8. And for the special test, there is advanced flow cytometry. For the chest X-ray thymic size, we can do the advanced test, which is examining the response to mitogens, antigens, and allogenic cells. The special test for that will be enzyme assays like the adenosine deaminase and purine nucleoside phosphorylase. And we can do also thymic imaging. For the delayed skin tests, the advanced tests are HLA typing and chromosome analysis, and the special tests are mutation analysis, T cell activation studies, apoptosis studies, and biopsies. Moving to phagocytic deficiency. Screening tests are WBC, white blood cells morphology, count and morphology. And the advanced test in this will be adhesion molecule assays like CD11B, CD18, and selectin ligand. The special test will be mutation analysis. Also, we can do respiratory burst assay or the neutrophil respiratory burst. The advanced test for that will be mutation analysis, and the special test will be enzyme assays like myeloperoxidase, G6PD, NADPH oxidase. And lastly, the complement deficiency, we can do mainly CH50 activity, and the advanced test for that is AH50 activity, and also we can do C3 and C4 levels. The advanced tests for them are component assays, and for the C4 level is activation assays like C3A, C4A, C4D, and C5A. Now moving to the questions part. The first question is, 9-month-old infant develops disseminated tuberculosis after BCG vaccine. He has previous attacks of diarrhea, pneumonia, and sepsis. CBC reveals a low lymphocyte count according to his age. Radiological study show very small sized thymus and absence of lymph nodes. Of the following, the most likely diagnosis is A. SCID, proton gamma-globulinemia, common variable immune deficiency, autoimmune polyendocrineopathy, candidiasis, ectodermal dysplasia, transit hypogammaglobulinemia of infancy. The answer is A. A combination of opportunistic infections and a persistently low lymphocyte count is an indication to test for SCID. Okay. Second question. On assessing a child who is suspected to have immune deficiency, which of the following investigations is the least helpful? In the real question in the book, it is mentioned nitro-blue tetrazolium test, but nowadays it is replaced by this dye, which is rhodamine dye. Okay, so we will consider as if they updated the book with this substitute. The second, acute inflammatory markers, serum immunoglobulin level, complete blood count with the differential leukocytes. The answer is B, acute inflammatory markers. It is the least helpful in screening for immune deficiency. Okay, moving to the next question. A 3-month-old baby presented with severe pneumonia needed mechanical ventilation. Also, he was found to have persistent oral thrush, which is resistant to treatment since 2 months. Investigation revealed that he is having severe combined immune deficiency. So here they give you the diagnosis straightforward. The question is, what would be the curative treatment for such a baby? I mentioned the answer in my presentation. It is bone marrow transplant. Okay, next question. 9-month-old boy presented with recurrent attacks of diarrhea, thrush, and failure to thrive shortly after birth. You suspect immune deficiency. Of the following, the most common cause of this condition is hyper IgE syndrome, defect in phagocytic cells, deficiencies in T cell function, defect in antibody production, defect in complement proteins. I mentioned regarding the early onset. So the answer will be C, deficiencies in T cell function. Children with defects in antibody production, phagocytic cells, or complement proteins have recurrent infections with encapsulated bacteria and may grow and develop normally despite their recurring infections, unless they develop bronchiectasis from repeated lower respiratory tract bacterial infections or persistent enteroviral infections of the central nervous system. By contrast, patients with deficiencies in T cell function usually develop opportunistic infections or serious illnesses from common viral agents early in life, and they fail to thrive. So next, a 17-month-old girl presented with history of recurrent attacks of pneumonia since the age of 8 months. You suspect a predominant B cell defect. Of the following, the best simple initial screening test is, I mentioned this in my presentation, it is IgA measurement. If the IgA level is normal, selective IgA deficiency, which is the most common B cell defect, is excluded, as are most of the permanent types of hypogammaglobulinemia, as IgA is usually very low or absent in those conditions. If IgA is low, IgG and IgM should be measured. Next, a very high serum concentration of one or more immunoglobulin classes suggests all the following except HIV, chronic inflammation, intestinal lymphangiectasia, chronic granulomatous disease, autoimmune lymphoproliferative syndrome. So the answer is C. There is a possible of loss of immunoglobulin through the urinary or gastrointestinal tract. Thank you very much for watching this video. I hope it benefited you, and I'll be doing inshallah subsequent videos more about the pediatric immunology. These are my resources: the Nelson textbook of pediatrics, Musawi question box, H&M MCQs. Thank you very much.